Welcome, everyone. Thank you all for being here tonight. I'd like to start with a special thank you to our panelists for generously giving up their time to join us this evening. We really appreciate it. And if you can go to the next slide. Tonight's event is titled Real World VIR, Life in Regional and Specialty Centers. And I'm actually really looking forward to the discussion that we'll have ahead. My name is Jason. I'm a rising M2 at Chicago Medical School, and I'll be your host for tonight. Before we get into introductions and our panelists, I want to take a moment to share a bit about what we do here at WCVIS Chicago. If this is your first time joining one of our events, welcome. We're a student-run organization focused on connecting trainees across the Chicagoland area and the broader Midwest with information and opportunities in VIR. You can find our link tree through the QR code on your screen, and from there you can fill out the membership form to stay in loop on future events, sign up for the mentorship program that we have, and then you can also visit our YouTube channel to catch recordings of our past events. And so with that, it's my pleasure to introduce our speakers for this evening. First, we have Dr. Kenny Yu. He's currently practicing at the City of Hope. He completed his residency at the University of Rochester Strong Memorial Hospital in diagnostic radiology and nuclear medicine, and then completed his fellowship at the same place in interventional radiology. Next, we have Dr. Suraj Gupta, who is currently practicing at Advocate Lutheran General Hospital in Chicago. He completed his residency in diagnostic radiology at McGaw Medical Center of Northwestern University, and then continued to stay for his fellowship in vascular and interventional radiology. Great. So I'm going to spotlight our panelists. Great. So before we dive into our questions, I'd love for each of you to briefly introduce yourselves in your own words, and then maybe share a little bit about your current practice and what drew you into IR.
All right, I'll start. So my initial interest was for DR. Got into DR, and during the DR, we had 6 months of rotation in IR. It was a very enjoyable time. Did not realize the hands-on component of radiology. After a month or two, my program director allowed me to basically go on my own, do the cases without any, much supervision. Loved it, enjoyed it with patient interaction, clinical aspects of it too. And then after my uh, residency, realized not only do I need to know how to do the procedure, but to know how to get out of trouble. So I decided to do my fellowship not only to learn the additional high level cases, but also to find out and find the results. Uh, try to get to the point of getting out of trouble that you put yourself into. So that was the main reason why I went to interventional radiology.
Right. Dr. Gupta.
Yeah, so I mean, briefly, I grew up in like Deerfield area, so local guy. Did all my training at Northwestern, and then landed at Lutheran, where I've been ever since. As far as why I picked IR, I have a lot of radiologists in my family, so radiology and its specialties were always kind of on my radar. But in med school, I was also drawn, and I was kind of torn between IR and urology actually, and decided to go with IR for a few different reasons, but very, very happy with my decision. Although I'm sure, urology would have been great too. Um, my practice at Lutheran, very lucky to be at such a big and kind of busy hospital. We do everything in IR and a lot of it, and it's really great. It's basically academic level care in a community setting with kind of a. I feel like it still has like a small town hospital type of feel where everybody knows each other, and
Mm.
it's very personal, and it's hopefully it doesn't become too corporate in the future, but it still has that feel. And I love it. And I hope I never have to go anywhere else. And We were part of a mixed diagnostic and IR group, a private practice up until just March of this year, until we became employed by Advocate across the whole system. And That really hasn't changed too many things as far as my day to day and my practice. And if anything, I think it might make some aspects better just because I think as IRs were in many ways more valuable to the hospital than we are to a diagnostic group. We'll see how it unfolds, but I'm happy to talk a little bit more about my practice, as we go along.
Great. Thank you, thank you for Dr. Gupta for explaining a little bit more about kind of your practice at Lutherans. Dr. Yu, I'd be curious to hear kind of, I know that you work at City of Hope, but
Mhm.
how long have you been there and how does your kind of day-to-day look like as an interventional radiologist?
So City of Hope came into play only a few years ago. It was a Cancer Treatment Centers of America. Started out with that in early 1980s. Then it was a one-man show, basically one guy who owns it. It was a for-profit organization. I joined that hospital about 17, 18 years ago after my short stint at Christ Hospital as a senior partner there. So I jumped ship from private practice as a senior partner to being employed a physician, which I got a lot of backlash for it. And they were actually, my fellow ex-partners were saying, you'll be back in 6 months. Well, that was 18 years ago. Retrospectively, would I have done the same thing? Absolutely. For me, the practice, the hospital is small. It's like 80-bed hospital, but they became famous because the level of service that they provided. I know there's rumors, years ago about CTCA, Cancer Treatment Centers of America, of a practicing non-conventional medicine, but when I got there, it wasn't the case. I would say they weren't the leaders of treating, cancer in a sense of, having, up-to-date medicine. However, they in, included not only the patient, but also the caregivers and put emphasis on them also equally because they're going through a very traumatic experience of their loved ones having cancer and everybody's writing them off. um, I have endless stories where patients were written off, but we treated the patients and years down the line they were still alive. So my practice at City of Hope right now is fairly small centers, but because of uh, word of mouth, people do come and fairly busy services. For in terms of IR, range from simple case like PICC line to Y90 cases. Um, I've done only a few of TIPS procedures, but the gamut of procedures that I've learned during my fellowship is available if I choose to do it. The only limitation is vascular work. Venous work, yes, but not arterial work because we unfortunately do not have a vascular surgeon backup if something goes awry. So we don't do arterial work. Um, it is a small hospital, like I said, and so everybody pretty much knows everybody, and for me, that is a huge change from Christ Hospital, where nobody knew anybody except for the ones that you interact on a daily basis. So, if you ask me which would I prefer, I honestly prefer what I have now. As Dr. Gupta mentioned, it's a hospital atmosphere where you pretty much know everybody, and that's a huge asset in my opinion.
Hmm. It seems like kind of like community within the hospital and being able to collaborate with others and is really important to both of you. I guess when we think of like community hospitals, at least for trainees, I think when we're looking to do our residencies, we're looking at like big academic hospitals to do our training. On like social media, like academic institutions kind of be the ones that are kind of out there. But I kind of want but to my understanding, most practicing interventional radiologists are actually at these community hospitals and regional centers. And so I wanted to ask what you guys both think are the most significant, like operational or cultural differences kind of between your practice and a major academic institution.
Dr. Yu, or you want to? Or,
Yeah, I mean, in terms of academia, for all the reasons that are included in terms of what you learn, what you practice, how you did things, I think academic world is way to go. However, for me, I had other responsibilities, especially financial responsibilities back in 2000, early 2000. The discrepancy between the private sector and academic was huge. So obviously I chose the path where it was pretty much double the income, the salaries double.
Hmm.
Now, in terms of what's available academic world versus small community hospital, is that the scope and the depth of pathology and the procedures. I'm sure Dr. Gupta is doing a lot more different range of IR cases, whereas I am not. For example, fistula. I don't do fistula because it's a cancer center and barely anybody has fistula. If anything, we just put tunnel central line for dialysis. So the scope or the depth of cases are limited. Okay. And then the other thing is, I would say on my daily practice, I am doing relatively about 80 to 90% DR stuff. It is a cancer center, so there's a lot of pathology, a lot of cross-sectional. Almost everybody who walks into the door gets imaging studies, CT or MRIs. So, oh, I also breast mammography. So I do everything. So I'm in a true sense of the word, even though I did my fellowship in IR, in a true sense of the word, I am a general radiologist. I do everything with IR at a higher level. Um, I also did a year of nuclear medicine, so that's another component of oncologic imaging studies that is required. So that's the gamuts that I practice currently.
yeah, in my practice, for anyone who's been to Lutheran or is familiar, like I said, it's very much like an academic place. I mean, it's 650 beds plus. There's a lot of different training programs, whether it's medicine or surgery, fellowships, in oncology and GI, which happen to be two of our big referrers. And so that feel of it is very similar to what I experienced as a trainee and as a fellow, which is great because, and especially the place like Lutheran, a lot of complex pathology. Are we seeing the zebras that you might see at a at a university level place? Not all the time, but you're seeing a lot of interesting stuff. And then as far as the feel as being a practicing physician in that group, um, I think it's amazing. Where I trained at least, and I would imagine at many of the academic centers, a lot of the faculty are siloed maybe in one or two disease processes. So, for example, at Northwestern, we had a DVT guy, we had a TIPS guy, we had an arterial guy, a biliary guy, et cetera. For me, on a busy call week, I'll do one of each of those cases at least. So, I may not be the expert in the portal hypertension as the guys who train me, but I do a lot, and I also do a lot of everything else. And so, that's one of the things that attracted me to IR, and that's one of the beautiful things about my practice that I love so much that I'm able to do really everything as much as I want. And at a hospital like that, it's such fertile ground for developing new service lines and practice growths. I mean, really, like they say, if you build it, they'll come. And now we've started a very robust musculoskeletal embolization practice. So we're doing tons of those, and it's really whatever you have the time and energy to invest in and to develop the service lines. And if you have those good relationships with the referrers, you can do it. Sky's the limit. So, I think it's kind of the best of both worlds. Certainly, I know I've moonlighted at other hospitals that are smaller and the feel's not the same, but, I think that I'm very lucky to have fallen into this hospital and this practice where, I think it's a nice sweet spot and it suits my personality and what I'm looking for, at least at this time of my life.
Mm.
Yeah.
Dr. Gupta, Doctor, you mentioned that his split between IR and DR is mostly DR. How is that split for you? Um, and is that something that's flexible?
You asking me?
Yeah.
Yeah. In my day to day, I'd say so every day I work, I'm in the IR seat and I'm doing IR, but I'd say probably about 10% or so of my work day is probably spent 10 to 15% doing DR, and majority of that is vascular related imaging. So CTAs, CTVs, some vascular ultrasounds, and then some pre and post treatment, cross-sectional imaging. And so for me, it's great because I don't want to give up those skills. I read kind of what I'm interested in and like to read. I don't like to read any neuroradiology, so I don't have to do any of that. And in my practice, I think it's a big plus to have some exposure or have a hand in doing some of the diagnostic work because I can't tell you how much business I've drummed up from reading studies. You read a CTA, there's a big splenic artery aneurysm. The refer well, the patient's on your table in a couple of weeks. Or DVT studies, or you read CT on a cirrhotic patient, and next thing you know, you're doing a TIPS or a Berto in a couple of weeks. So um, I think it's nice to have access to that, and it is what you make of it.
Great. So I know you guys both mentioned that being able to kind of know everyone in the hospital is something that was valuable to both of you. But I'm curious to know, what are some other things? What's your favorites and least favorite aspects of kind of like practicing at a non-academic kind of center?
Yeah, I can go.
Yeah.
So I think the favorite things, I think I alluded to a bunch of those factors that we discussed. Least favorite things, I think, is a call. Currently I'm one of three doctors at this big, busy hospital. So I'm on call every third week for the whole week, 24/7. So even though I may not be coming in all that time, I'm sure not as much as Dr. Yu was coming in at Christ, because that's a whole different animal. It's a lot of time where you're mentally occupied or you know can't have plans on weekends and whatnot. Since becoming employed, now we're kind of merging with Kandal Hospital, so we will have a couple extra guys in our call pool, but then cover another hospital. So I think that that'll be a big plus that goes live in a couple of weeks. But I think compared with my friends, I have a friend at MD Anderson, and he takes not even two call weekends per year. And
Mm.
I was taking 17, 18 weeks a year for the last 8 years. So as you can imagine, that's it's a big difference. And the other thing is that having moonlighted at places and knowing um, people at other hospitals, I'm fortunate that at Lutheran, being a teaching hospital, it's a high level of care, and the expectations are high, and you don't get a lot of calls or bothered about nuisance stuff, which is nice because I know that that's not always the case at every practice.
So I chuckled when you were talking about the calls. I wasn't laughing at you. I was laughing at the circumstance because I'm actually the opposite. I enjoy my calls because my calls are non-existent pretty much. Went from Q3, and one of my IR uh, coworker left, went to Irvine and went to Q2. If you ask me in the last 18 years how many times I've gone in to do a true emergent cases, I would say maybe less than 10 times. One time I got called at 2, 3 o'clock in the morning for a bleeder who's a Jehovah Witness, went in. She was up and about talking. I reamed out the surgeon who called me to wake me up and call me in for that case. So call for us is pretty much, it's non-existent. So that's the beauty of it. What I don't like about it is the fact that, Dr. Gupta, as he mentioned, he has a huge range of IR procedures that he was taught, learned, and the depth, you know, of it. So that's what I don't like is that we don't have that at my center. It is a subspecialized hospital. I would say about 90+% of patients are cancer patients. So a lot of what I do in IR is geared towards them. So
Mhm.
that's probably the least favorite component of my practice.
Yeah, so what are some other favorites, some things that in your current practice?
Well, like the group that mentioned, getting to know, know everybody in a personal level, physician-wise. They know your skill set, they know your abilities. They're not, their threshold for referring or consulting you is very low because they know it gets done. We provide services pretty much either on the same day or the next day. We're not as busy as Dr. Gupta, but we were able to offer services on a very, very timely fashion.
Mm.
Before COH, we used to provide, you know, getting the patient in, making the diagnosis, and start the treatment in 3 days. That's pretty much unheard of for pretty much in any institution. And we were able to do that for, 15 years. With COH, a little bit different. Their timeline is a little bit lengthier, but still we are able to offer, procedures or biopsies within, a day or two.
Mm.
Uh, we just have to pick up the phone and or text each other and get things done. So that's one of my other favorites.
Sorry, Dr. Gupta, did you have any other favorite aspects of working? I know that you mentioned some of that you didn't really like the call part, but
Yeah, no, I love my job. It's, like I said, it just fits my personality and stage of my life where I like to be really busy. I'm kind of an adrenaline junkie. So I like to do big cases, difficult cases, a variety of things, variety of diseases, work with a variety of different specialists. Um, I wish we had trainees. But we don't, at least in IR.
Mhm.
But I like to, give lectures to the residents and the fellows at different specialties. We actually just hired a new partner who's fresh out of, training, and I'm really excited to work with him because any new person coming out is going to need a little mentorship. And I'm also excited for all the cool new stuff that he probably knows that I don't know, and so he can teach me right back. So, yeah, that's why I love my job. It's every day is fun. There's never been a day that I've like dreaded or not want to go. I mean, of course, there's days that you want to stay home and do nothing, of course. I've never had a day where I didn't want to go to work or wasn't excited about it.
That's awesome.
So
That's great to hear.
I feel very lucky in that respect.
Mhm.
Many people can't say the same thing, so I feel incredibly fortunate.
Agreed.
We had a speaker previously for our events where he talked about the VIR job market. And the speaker was Dr. Desai. He was talking about how the job market is very broad in IR. There's working at academic institutions, OBLs, locums, community hospitals. And so there's all these places that you could technically work after you graduate from residency. Do you think then it's kind of a personality fit between the places that you work at? Like, what are your thoughts on that?
Well, I mean, for
Yeah,
me,
go
sorry,
ahead.
go ahead.
No, no, please.
For me, I think a lot of the attractions were family oriented. As I mentioned earlier, my wife is from Chicago area, so am I. I just went to, University of Rochester undergrad and then practiced there or trained there. But it was inevitable that I come back to Chicago. Um, that's probably one of the things that I would encourage you guys is to look at programs where you might potentially want to settle. Because to break into Chicago arena from, Rochester, New York was a little bit, daunting. But luckily for me, the group that I joined was expanding and they were looking for IR guys. And I don't know if you, Dr. Gupta, I'm not sure. I'm sure you were aware of Alexian Brothers. I was there
Mhm.
initially, and when I got there, IR was non-existent. So build it up and it became successful. So that's one of
Mhm.
my advice is to try to get into a program where you might potentially stay in the long run because by then, local practices know you, and that's huge. It's no longer what's your GPA, what's your USM on the exams. It's about word of mouth type of
Mm.
thing. So,
Totally agree with that. For me in my job search, number one was geography. I wanted to stay close to Chicago. Of course, I did all my training here, but that's where I grew up. My wife was kind of from all over, and so she was willing to stay wherever we found a job. And the network is huge.
mhm.
When I was looking for a job, there were not a lot of great jobs in Chicago at that time, and I'd actually was getting geared up to join a job in Indiana, not too far, but then literally at the last minute, a job opened up at Lutheran, and I was able to get it because one of the current doctors there was a fellow a couple years ahead of me, and just during my job search, I just had kept in touch with everybody a couple years ahead of me and a couple years below me, and so I think the network and the local, network is huge. At least it was very helpful to getting these jobs because most of the good jobs are just by word of mouth, as Dr. Yu said. Um, and as far as other factors when choosing a job, I think it all depends on what you're seeking out. I think the era of private practice IR, at least in a mixed group in a metropolitan area, is probably dead or close to dead. And I think that most of the IR jobs going forward, unless you're in the small town or rural areas, are going to be employed, which is not necessarily a bad thing. Because as I mentioned before, I think that we're more valuable as IRs to hospital or to the hospitals than we are to necessarily a diagnostic group where, your worth is based on your RVUs, which unfortunately, we're at a disadvantage now. But in the same token, if you want to have some diagnostic responsibilities as well as IR, like Dr. Yu does, and that's important to you, I think that those opportunities can be found, but they're probably less common because, as an employed IR, you're probably going to be mostly doing IR. Um, and then as far as other factors, for me, I knew I wanted to be busy and do a wide range of things, and so I think that being at a place where the practice is busy and you're not necessarily the only doctor working at a site, at least early on when you're still learning, and having partners who can mentor you, um, that was a critical factor for me in just my development.
Mm.
And I feel like a lot of young IRs are in a similar mindset, and I think finding practice like that with partners and big case mix can be helpful.
Mm.
If I may add to that, when I was getting out early 2000, we had the luxury of wanting to just do IR.
Mhm.
But that's no longer the case. Unless you go academia or like Dr. Gupta's practice, if it's super busy IR, then you could, concentrate most of your time there. But it's no longer the case with a private practice. If you join private practice, you have to read DR stuff.
Mhm.
And my practice is small, so I chose to do that much more DR because, as you mentioned, it's RVU driven. So you get a lot more RVUs because you could read a lot more within that time frame than doing procedures. So I saw the light and I went towards that light, even though I am IR trained. Uh, it's an interesting thing that one of my ex-partner asked me was in the very beginning of my other practice. He asked me, "Can you live without IR?" And he was shocked with my answer. And I said, my answer, I was like, without hesitation, I said yes. Because as I mentioned, I went into DR thinking I was going to do DR, but then kind of, you know, chose to expand my skill set to do IR. So my answer was yes, I could live without it. And he was shocked because his mindset was IR is the only way to go, period. But again, that's not the case right now. I would say, what would you say, about 90% or so, unless you're in the academic world.
Yeah, I mean, it seems like from both of what you said that there's a lot of different factors to consider for maybe where you'd want to practice, including like things you can't necessarily control, like the generating RVUs, like mentorship, places you might want to settle, the variety of cases, and like knowing what you want for kind of your career. Um, so there's definitely a lot of things to think about as trainees.
Mhm.
But I also wanted to ask with the next question, what are some of the most common misconceptions about kind of your practice type that you wish kind of trainees would have known beforehand or would understand, would like to know?
Well, I mean, not necessarily misconception, but for me, when I finished my fellowship, I had a rude awakening of how much of business component that I am ignorant of. Even looking at contracts, even kind of negotiating contracts. None of that were spoken of or advice of. So I wish that component of our practice overall would be incorporated into either into medical school or in residency. Um, so that was my severe lack of knowledge that I had, which it took me years to try to get on board and affect positive change for myself. But for you guys, I think that's something that I encourage strongly to get to know as much as you can.
Yeah, going off with that, Doctor, you brought up a great point. Then what is one aspect of the business side of practice that you wish you had learned more about during, your training period, medical school residency or fellowship?
So for me in the private practice, obviously in any business, there's a lot of overheads, right? So, I have no backgrounds in business other than, working at a commercial store, years before my uh, medical school, doing the books, things like that. I wish I knew that, and also get involved with the my private practice as to find the details of what we're making, what are the overheads, and how much can we what we can do to maximize our profit. Those are completely you know off the wall for me because um, main thing is because I was not knowledgeable in that arena. Um, so that's where I wish I would have had more. involvement. Uh, yeah.
Yeah, I agree. I think that stuff is very important. Certainly in training, you're focused on learning how to be a good doctor and learning how to do the cases. I think there's a lot of good resources out there. I listen to Backtable all the time, and some of my favorite episodes are the ones that aren't about techniques or about, business, business topics and this and that. And I know SIR at the meetings and, on the website, they have some literature and some resources to that effect as well. I think whether you're in private practice, I was in private practice for 8 years and, being on the board and trying to learn some of those business aspects of it, the revenue cycle management and all the input and outputs are so important. And I think that that's important even now. I mean, I'm just a couple months into being employed, but, you know, those are the factors that are important for the administrators. And whether you like it or not, you have to understand it and be able to pitch for what you want and what you need. And so I think that if you speak that language and then you can color your requests with saying the right things and showing the right data to get what you want. And also, if you want to rise to a leadership position within, a corporate structure, um, and then also, it's fascinating. I have a few friends who are starting their own OBLs and labs and such. And I just tell them, I'm like, let me just come hang out with you and I just want to learn about the business. I'm not trying to start my own OBL by any stretch of the imagination, but I think it's just important to know and understand and see where the specialty is going because I think all those factors they kind of operate in the background and they affect us all. And the more you understand how they work and where things are going, then you can be prepared for what's coming because the economic side of things is rapidly changing. I think it's just best to be prepared and knowledgeable.
Hmm. Is this like this learning this business side of IR, is this something that you can escape if you go into um
No,
academia?
talking to my friends who are academics, so now, that I'm an employee, at least for the time being, our compensation is tied to RVUs and productivity. And, before when I was private, even though I was part of a private practice, I was kind of in this ignorant, blissful bubble where I just took care of patients the best I could. And, we were paid well and, most of that was subsidized by the diagnostic folks. I say subsidized, but, they wouldn't have a contract if it wasn't for the IR folks taking all the call. Now, I'm a lot more tuned to what are the RVUs of the procedures that I do. And, not that, I try not to let it affect how I practice, but um, if anything, it's made me a better, made my reports better and my dictations because how I'm paid, or reimbursed is based on me documenting everything that I've done and so that there's no money left on the table. Um, and so to your question about academics, I think that at a lot of academic places or other employed positions, the compensation structure is similar where you have to understand the RVUs and the things that are worth your time, things that may not be, and sort of how to make that all work.
Great. At this time, I'd love to kind of open up this discussion to the audience. So if you have any questions for Dr. Gupta or Dr. Yu, feel free to drop your questions in the chat, or feel free to unmute yourselves as well.
I have a question. This is directed towards Dr. Gupta. At the beginning of the panel, you discussed how MSK interventions started to become a
Mhm.
little bit more popular at your hospital. I'm wondering what that process looks like. So who brings that up? How does it get implemented?
Yeah, yeah. So, as you know, they've been kind of coming into vogue in the last, few years and covered by insurance, no longer experimental. And so, with resources like Backtable and, my friend group, just keeping abreast with new technologies and techniques.
Mm.
Um, it was something I'd read about, and just, by luck, one of our rheumatologists started asking if we do them, and we just jumped on that opportunity. And of course, it's a two-way street. You have to, be available and provide a good service, and choose your patients. Not just try to do things for the sake of doing it, but and that has just grown tremendously. And we are getting tons of referrals from rheumatologists and sports medicine docs and primary care docs, and all sorts of people are hearing about this magical new procedure that we do, which
Mhm.
you know people are doing all over the place. So a little bit of luck, absolutely, and a little bit of just um, working the refers and providing a good service, and I think putting yourself out there. I think that the more that people know that you're doing something, and that you're taking care of patients, then they're happy to help you. At the end of the day, a lot of these refers, they're stressed out because patients have all these problems, and it all kind of, the burden falls on them. So the more that they know that there's someone that they can call that can help, and that person's willing, then they're more than willing to send patients to you, and to send business to you.
Great, thank you.
We have a chat in the from the audience. It's from Yahia. He asked, "How do you implement a new procedure if it's something you haven't done before? How do you continue to learn after your fellowship training, etc.?"
Yeah, I mean, that's, in my first year of being an attending, despite doing a lot in fellowship, there's a lot of things that I had to learn how to do. And along the years, there's a lot of things that I do that I was never taught to do, that it just wasn't a thing. When I was training, like biliary endoscopy and prostates and um, musculoskeletal embolization. So I think that the key is to train in a facility where you can do as much as possible and have as much, in my opinion, independence and autonomy as possible to really learn how to be confident in yourself and to how to get yourself out of trouble, as Dr. Yu was saying. And then just stay current with, what the trends are, what people are doing, and I think be safe. Know your limitations. Don't try to be a hero. And you'll get a lot more respect for saying no to something, or to, back away, than to get yourself into trouble and have a complication. So I think, in any practice, but especially in a practice like mine, your reputation is everything. And so it takes a long time to build, but you want to be known as a doctor that's safe and reliable, and is doing what's best for the patient. And I think that the more that you just kind of tread slowly, and not bite off more than you can chew. The experience and the comfort level will get there with anything new. And if you have an interest in learning new things, I think that that's part of the culture of our specialty, where you'll be well equipped to do so. Because there's always, every year there's going to be something new that people are doing, and if you want to build it, people will come.
Yeah, I mean, I like to believe that almost every IR program in the United States will give you the foundation that you need to do any cases, even if it changes a bit or if a new procedure comes out, um, you will be able to do it. There's certain procedures that, I was not taught, but you know what, you know, putting catheter, micro catheter in somewhere. If you know how to do that, you could get to any places with with what you have learned. So I would not be concerned about promoting or starting up new cases, but knowing your level of comfort, like Dr. Gupta said, you don't want to burn bridges by attempting a brand new case which you've never done and you're not comfortable with, um, because that will basically ruin the referral. If being honest with them, I've set cases where, hey, I've never done this, but I will try my best to do it. And knowing your limitations, when to say when is so important in our field. You can't just bulldoze, into any case and every case. You got to know your limitation, and knowing when to say when, like the group that I mentioned, is so valuable for not only yourself, but for the patient care and the referral.
Great, thank you. We have another question in the chat. And Mohammed is asking, what factors would make you choose ESIR versus DR, then IR fellowship? And what do you all see as the pros and cons of each?
What is E? Sorry, what is E? What E? What?
Yes,
ESIR.
Probably after my time, right? What is that?
uh, the
I
early
mean, those
specialization.
paradigms were just started right after my time. I did the traditional way,
Okay.
as I'm sure
Me too.
you did. And I get asked that question a lot. And to be honest, I don't know all the ins and outs. I would just say that wherever method, whether it's ESIR or integrated or whatever, just try to go. If you know you want to do IR, um, try to go to, and I'm sure you'll get great training everywhere, but go where you think you can get the most reps, do the most amount of cases, the variety of things, you know, get a lot of autonomy, because I think that is what's going to make you comfortable and a good operator. If that's your goal, is to do a lot of cases. And if it means doing an extra year, in the grand scheme of things, one extra year is no big deal. And to be quite honest, if you do 4 full years of diagnostics,
Mm-mm.
that's not a bad thing anyways, because I think the better diagnostic radiologist you are, you truly are a better IR doc.
Yeah.
And if you have a job where you're doing a hybrid, of diagnostic and IR, you're going to be all that much more valuable to that group. Like Dr. Yu, he does nuclear medicine. I mean, someone like him is a diamond in the rough as far as being able to do everything, which is incredible. So I would harp less on trying to get through the training as quickly as possible, or try to be in some integrated program if it means let's say if you get a diagnostic radiology residency at some place with a good IR fellowship, but it's hard to get the integrated program. In my mind, if you go there, get good diagnostic training, network your butt off, stay there for IR, ESIR, whatever, I think you're going to be in a better spot, even if it takes you an extra year. But again, those paradigms didn't exist when I was training, even though it wasn't that long ago.
Me too. As I mentioned earlier, my ex-partner asked me about whether I could live without IR, and my answer was uh, uh, distinct and rapid response, which is yes. For those of you who wants to go into integrated program, and that was like spoken to when I was finishing up my fellowship, or spoken about. If your heart is set on IR, like my ex-partner who can't live without IR, and you mainly want to do IR, and I think that's a lot of it has to do with going to academia. Like Dr. Gupta, even though he's an academic center and does majority of IR cases, now as being employee, RVU comes into play. Just historically for me, I went from a senior partnership, okay, where I did majority of IR at Christ Hospital. I was doing like what, 20, 30 cases a day, to it being employed 18 years ago. And now my, salary is doubled or even more because of RVU base, because I'm doing more reads. If you want to go to private practice, I mentioned earlier, you have to read, or else they'll boot you out. You probably won't make partnership if you don't produce. Okay, you could be the best IR guy, but if you don't help the rest of the group read films, you're not their asset. Like Dr. Gupta said, hospital loves you because you have the skill set to do all these cases, procedures that not other specialties can do. But if you're part of that group, private practice, you're not a huge asset because you're not going to bring the RVU, the amount of RVUs that they could generate. So it's a huge toss up as to what you really want. Um, For me personally, it wasn't just IR, as I mentioned earlier. So it was easy for me to go into, well, we didn't have it there was not an option when I trained, but so I did a 4-year diagnostic and then do fellowship. Um, I
I would
highly,
just add, sorry, go
sorry,
ahead.
if you don't know
Go ahead.
which way you want to go, I highly recommend really learning DR, even though you're in the integrated IR program. I'm sure you have to rotate right through DR, I think.
Mhm.
Yeah. Okay.
Yeah, I was just going to say, I mean, you spend at least 3 solid years learning diagnostic in any program. And I think it's foolish to let those skills go away.
Yeah.
Because I know plenty of IRs that, even though very few IRs, I think, continue doing IR for their whole career unless they're kind of academic through and through. A lot of people slow down or they transition into diagnostic or they stop taking call, et cetera, um, at least in the non-academic community world. So I think it's foolish to give up those skills that you spend a lot of time learning and you take boards for, even if it's just doing a little bit. And if you do end up with a 100% IR job at academic place, there's all sorts of opportunities to moonlight or to do some diagnostic reads just to keep those juices flowing. Because once they're gone, it's hard to get them back.
True. Yeah.
Like for example, I stopped doing any neuro like once I started my job, and I kind of wish I'd kept up some of those skills because I got pretty good at it in training. Um, and now the ship has sailed. And if I was able to do that, I'd have a lot of opportunities available to me for side work.
Hmm. I mean, it's pretty much proven that you're smartest in your 4th year or your fellowship. After that, it's
Yeah.
downhill, boys.
Great. We have time for one more question. And there's a question in the chat. If advising someone that was looking to work in IR in a similar setup as where you currently work, what would you say to look for? What kind of region, hospital practice would you target, and what to look for in the scope and responsibilities of your role?
One of the questions that I do ask over and over to the applicants is geographic, like Dr. Gupta said earlier, his reasoning for applying to certain areas. Geographic is very important. Family is very important because odds of them coming if they have a family member locally is very high. Um, Ones that do not, they're just throwing darts at this place, that place to see what the hospitals could offer them and things like that. So if you're truly interested, I think geographic concentration where your family is pretty important. Other than that, if you don't have family, like I mentioned earlier, uh, you know, network in that location, practice or do your training in that location, and then get to know the local practices as much as you can.
Dr. Yerpa, do you have any thoughts?
Yeah, just to recap, the question was, how would you advise someone to find a practice? Can you just repeat the question real quick for me?
Yeah, so if you were advising someone that was looking to work in IR in a similar setup as where you are currently at,
Yeah.
what would you say to look for? Is it what kind of region, hospital practice would you target?
Oh, got it, got it, got it, got it.
Mm.
Yeah, well, I mean, just to echo what Dr. You said, just first off, I think geography is very important. Especially if starting a family is in your life plan. Um, More often than not, I have friends from college, people spread out all over the country, and then once people want to settle down, they try to stick close to home. So, certainly people escape that, but always keep that in the back of your mind. As far as a practice, you know, like mine or something, I just to echo some of the things I said before, um, I think a bigger hospital is nice that, there's just more volume, more pathology if you're looking for doing a broad range of things. I think early on in anyone's career, it's good to work at a Christ hospital or at a Lutheran hospital or someplace where you're doing a lot and seeing a lot of different stuff to really hone your skills and solidify them and your confidence and your ability to do, a whole bunch of things. Because if you work at a smaller place where you're not doing much right out of training, that confidence and that familiarity go just like it does with diagnostic, it goes away pretty quickly, I would imagine.
Mm.
Um, so, I think that's important. And I think that having mentors and people that can kind of guide you because, 1 or 2 years of IR training is not enough. Once you start doing those cases by yourself, you're going to want people to look over your shoulder and just, confirm that you're seeing what you think you're seeing. Um, and so that's really important. And I think that, finding a place that is, as fair and kind of democratic as possible. And I think that now, since a lot of IR positions, or at least 100% or mostly, are going to be employed, I think that might be easier because kind of the pyramid structure of a private practice, where you have to build your sweat equity and put in your time and in some cases, and fortunately my group wasn't like this, but I've heard horror stories where the some of the senior people will use and abuse the younger folks. Um, if you can avoid something like that, if at all possible, I think that that's to your benefit, just so that you can have a ability to learn and do a lot. And I think, honestly, even if you're not in the best, financial situation or practice, I think that if you almost use your first, job as an opportunity to extension of your training to build your skills and your confidence and, independence, then from there you can go off to do wherever you want. And then if you want to work at some boutique hospital and be the solo guy and do everything, then you feel comfortable to do that. But it's hard to do that right off the bat.
Great. In the interest of everyone's time, since it is 8 o'clock, we'll wrap things up here. I want to extend a sincere thank you to Dr. Yu and Dr. Gupta. Your insights were incredibly valuable, and we're super grateful that you took the time to be with us tonight. And thank you for everyone who joined. We hope to see you at a future WCVIS Chicago event. Have a great night, everybody.